Respected Professor Asivaram sir, respected senior colleagues, my dear junior colleagues, it's my great pleasure scientific committee approached me, Professor Dr. GVK approached me, and not only cover the epidemiology, cover the basics and management and investigation aspect also in cover, so that I have prepared slides accordingly. So my agenda of talk will be like this. After a few minutes of prevalence, I will highlight about pathophysiological factors which predisposes to diabetic syndrome and investigations, management. And the moment they asked Indian data for prevalence of peripheral arterial disease. So naturally everyone like to search this diabetes atlas by IDF. So latest IDF atlas I searched. To my disguise, I couldn't find any data pertaining to PAD. But this IDF, they pooled data of all the cardiovascular diseases like coronary artery disease, peripheral vascular disease, as well as cerebrovascular disease, everything pulled together. And they give data, and out of 6.3 million people screened after searching so many articles from Medline's corpus and the multi-centric, the countries representing all the continents, Asia, Africa, China, America and Europe, and they give only this data. So, and findings from these studies indicate that compared to those without diabetes, people with diabetes has 60% higher risk of developing any form of CVD and 73% higher risk of developing myocardial infarction, 54% higher risk of developing stroke like that. So the PAD incidence according to them is very little, so they are not highlighted. So I searched some other articles. So I put before you some of the international articles with international data. Finally I come to Indian data, and this is one latest published in May 2024. So this paper shows the worldwide prevalence is expected to be 1.52% only. So but what we see in our hospital is more than 20-25%, in some studies 30%, 28%. Why this only 1.5%? I will tell you a little later. In low and middle income countries 5.1% above the age of 40, and high income countries 7.4%, rising to 14.92% in those over 80 and higher in females. And this is a study from HANES, that is National Health and Nutrition Examination Survey of USA. From the United States, the prevalence of PAD among adults aged above 40 years is 4.3%. And the same HANES study, it showed different age-wise split up. So 0.9% incidence in younger age group between 40 to 49, 2.5% between 50 to 59, and the incidence increases 4.7% as it goes above 60 to 69, and 14% above age of 70, and 23% above 80. So as it's clear to know that as age advances, the risk and incidence prevalence is going up and up, coming to the 23%, which we see in our routine hospital setup. And this the American College of Cardiology, and they say asymptomatic 20-50%, atypical 40-50%, classical claudication pain is present in 10-35%, and threatened limb, that is critical limb lesions, they are very little, that is 1-2%. This is one more study, international study, in San Diego population study, the survey of 343 randomly selected participants. Black Americans had a significantly higher prevalence of PAD, 7.8% versus 4.9% compared with white Americans. So black Americans has higher incidence of getting PAD. A systematic review which identified 14 studies comparing the previous prevalence between South Asian and white European individuals. Among those at high risk of PAD, the occurrence of PAD was less in those from South Asia. So this was the important thing. In South Asia, the incidence of PAD is less when compared with white Europeans. And in a review of 1,33,750 females and 71 males who underwent voluntary screening for PAD, the females were significantly more likely to develop PAD when compared to males. So this study also, many studies are contradicting. So majority studies, they say females are having more preponderance to develop peripheral arterial disease, but in some studies, male also, they score over females in developing PAD. And coming to this one more study, the epidemiology and burden of peripheral artery disease, a systematic literature review. And this systematic review searched Medline, Embase, Cochrane library databases of 4,445 potentially relevant publications. 195 were screened based on full text and 87 were included in the final analysis. In the two large multinational randomized control trials, Barry 2D and advanced trials, which was done from throughout Asia, Australasia, Europe, North America, the prevalence of PAD was 19% in people with type 2 diabetes and documented stable CAD, and 22% in those with type 2 diabetes who had at least one additional risk factor for CAD. Then coming to the Indian scenario, in India, by an average, 14.4% of people has peripheral artery disease, type 2 diabetic patients. So mortality rates 5 times greater in diabetic patients than in non-diabetic population. This is a worst scenario. And I will put before some of the journals, this prevalence of peripheral arterial disease, I think this from Kanpur, Uttar Pradesh, it concluded PAD prevalence is 25%. And the risk factors significantly associated with the PAD were higher with age, with a higher HbA1c, and the prevalence of PAD seems to be higher among men than women. So some studies show men preponderance and some studies female preponderance. Patients with the peripheral artery disease have significantly more increase in carotid intimal media thickness. So this is how, so when any patient having peripheral arterial disease, we should look into other macrovascular diseases, like we should screen for coronary artery disease as well as other CAMT to prevent any major cerebrovascular disease. This one more Indian study, prevalence of peripheral arterial disease among individuals with type 2 diabetes in India. And it showed 23 articles, it's a systematic review, and 23 articles met the inclusion criteria, complained of 1,96,883 individuals with type 2 diabetes aged between 30 to 80 years, and the prevalence is 18%. And I should mention about this Indian consensus statement for the management of lower extremity peripheral artery disease. So this consensus was prepared by 19 experts across India from various specialties such as cardiology, endocrinology, vascular surgeons, endovascular surgeons, diabetologists, interventional radiology, podiatrists. And with this consensus, it showed global prevalence of PAD among adults aged 25 years and above was 5.56%. And this is the split up they have given. The whites have 17% incidence, blacks have 25%, East Asians 13%, whereas South Asians only 7.6%. This agreed by the consensus statement. These are the individual data given by this consensus statement. So Agarwal et al., Saran et al., Eskal et al., Pradeepa from Dr. Mohan's Diabetes Center, Shukla, Krishnan, Arora. So almost prevalence ranging from 7.6 to 14.4% in one study, 36% from Lucknow, Northern Kerala 26%. Like this, various state across gives different this thing. So this study of prevalence of peripheral arterial disease, it showed the men 16.9% and women 14.4%, and the two large studies. So in the hospital studies, the prevalence is 16%, whereas the two large studies, namely by Mohan et al. And the CUP study, found a prevalence of PVD 3.9% and 6.3%. But why the difference? When our hospital setup, incidence is high, 16%, 20%, 23%, but in the Mohan's study as well as this CUP study, only 3.9% is because it's a CUP study. These are community-based studies reaching out to normal population, whereas in hospital we look into the high-risk population. And this one more study from coastal Karnataka. So this also showed this ABI if it is 0.4 to 0.9%, 27%, 8%, and 65% has normal, 21% has above 1.3, and 4% has more than 1.5. And the cross-sectional study on prevalence of symptomatic peripheral vascular disease, so it showed the results is 25% of patients had an ABI suggestive of peripheral artery disease in study which is high costing. So this also fit well with the in-hospital studies. It shows high, starting from 16% to 25%. And then coming to the importance. So whenever any patient is having peripheral arterial disease, that particular person has high risk of developing cardiovascular disease also. And the peripheral arterial disease is considered as a systemic atherosclerotic marker. In some of the studies I have shown, the patients with PAD, they have increased carotid intimal medial thickness, like that, some other things. And the quality of life is very poor when a patient is getting PAD. And the worst thing is socio-economic impact. One person getting this PAD, the entire family and the family's economy will be shattered in due course, as unless you intervene aggressively in the early stage, it will be a pathetic situation for the family. So the main concern about PAD is 2 to 4 times higher risk for amputation in diabetic patient, and prolonged hospital stays when compared to non-diabetic population, and the critical limb lesions are more in diabetic patients, and multi-drug resistance is seen with peripheral arterial disease with any infection, and the mortality rates 5 times greater in diabetic patient than in non-diabetic population. Coming to the pathophysiology, we all know about this, and to highlight this on schematic representation, the hyperglycemia, whenever there is glucose excess, it will lead to the every byproduct of glycolytic cycle, it produces havocs in the metabolic derangement. So when the hyperglycemia, it produces polyol pathway, and if when it comes to this level, fructose 6-phosphate, hexosamine pathway, and glucosamine, and this glycerol 3 phosphate, from that it goes on to protein kinase C pathway, and ultimately the AG, advanced glycation end product pathway. Of course, among the all polyol, hexosamine, and protein kinase and AG pathway, PKC, protein kinase C, is the worst thing which increases the inflammatory markers. And this PKC produces diminished nitrous oxide and endothelin, increased VEGF, and tumor growth, increased collagen, fibrinolactin, and increased tumor necrosis factor alpha, and NADPH oxidase, and increases reactive oxidation species. Ultimately, it lead on to this vascular endothelial damage. And this is the interlink between hyperglycemia and the development of macro and microvascular complication, starting from RAS, increased elevated RAS pathway, altered increased production of AGEs, and all these interplay of inflammatory markers and fibrosis remodeling, and producing this vascular damage. And of course, this schematic representation, how the atherosclerosis develops with multiple factors. And we should know about the associated risk factors: smoking, hypertension, dyslipidemia, and obesity. In any patient with the PAD, we have to address these risk factors also. Coming to the symptoms, the more than half of the patients are asymptomatic. So the reasons attributed was diabetic people with peripheral, chronic diabetic people, peripheral neuropathy, they have loss of pain sensation. That's why this was the postulated. Okay, so symptom, most of them are asymptomatic, and many people have different symptoms, and only 1/3 have claudication pain, and the remainder have more severe form of illness. Coming for evaluation, it's a very simple, only one single test. It's endorsed by across world is ABI, ankle brachial index. In our routine practice, we should do for all patients ABI at least once 6 months or once in a year, and less than 0.9 indicates PAD, and it's a non-invasive, sometimes falsely normal. And nowadays, because diabetic people will have segmental block, multi-segment blocks, sometimes, most of the times, when we feel, when there is any looks like symptoms of PAD, when you palpate, you may be feeling the posterior tibial artery pulsation, you may be feeling that dorsalis pedis artery palpation, but still patient have some gangrene, progressive gangrene in the toes. So that is the reason behind this. Diabetic people will have segmental block. Okay, because of this segmental block, the toe gangrene is very common. So toe brachial index is a very popular and accepted by vascular surgeons. And of course, duplex ultrasonography, that is vascular Doppler studies combining with the B mode and the Doppler. And just for information, these are the normal values for the this ankle brachial ABI. So more than 1.4 indicates calcified vessel, and 1.1 to 1.4 normal, 0.9 to 1 acceptable, 0.8 to 0.9 some arterial disease, less than 0.8 moderate arterial disease, less than 0.5 severe arterial disease. So these are the indication for referral to vascular surgeon. In the highly calcified vessel also, we have to refer to vascular surgeon, and if it is less than 0.9, better we should refer to vascular surgeon. And coming to the evaluation, the further evaluation, the CT angiography is the gold standard, and the MRI angiography. MRI angiography is the gold standard, high resolution, and it has no radiation. And digital subtraction angiography nowadays available in very few selected centers, but this is supposed to be the gold standard, invasive, but very, very accurate. And some biomarkers we should know, the NT-proBNP and cotinine, high sensitive CRP, homocysteine, osteoprotogerin, and cystatin C. These are the biomarkers. If facility is available, we can do these biomarkers. Coming to the management should be holistic, and there should be multidisciplinary approach. There should be emphasis on team-based care, including diabetologist, vascular surgeon, podiatrics, and wound care specialist. It's not a single person cannot achieve success in this management of PAD. And we should consider quality of life also while treating the patient. So we should give medication for alleviating the pain. We should give good mobility for our patients, and the limb salving should be the priority. But once any patient goes for amputation, the entire family may be shattered. We have seen many families shattering after this amputation. And coming for the pharmacological treatment, so every journal, every textbook highlights about the glycemic control, and antiplatelets, aspirin and clopidogrel, and heparin in suitable patient, in critical limb patient, limb lesion, and oral anticoagulants should be considered. And when your patient is on heparin and oral anticoagulants, beware of this coagulation factors. This prothrombing time should be, and statins. Usually, whenever there is PAD, moderate to high intensity statins should be given, and suitable antibiotics. And the importance of hyperglycemia, then and there, everyone will be highlighting, because if blood sugar is more than 400, there will be defective opsonization and defective bactericidal activity. And hyperglycemia usually it depletes cellular immunity, as well as it reduces humoral immunity, and it impairs the complement cascade also. And it has been proved that consecutive 4 readings of more than 400 was associated with a significantly higher risk of mortality, as well as infection, as well as the risk for coronary artery disease. So at the most time, we should control hyperglycemia effectively. And already I have mentioned, we should keep it in mind, PAD is a cardiovascular risk equivalent. We should look into other atherosclerotic factors. And the importance of early detection and management is for prevention of the late complication. And coming to the lifestyle modification, every patient we should emphasize smoking should be stopped at any cost. We should holistic approach. We should call all the family members to counter this stopping of smoking, and exercise, diet, everything should be given. Coming to the revascularization, the endovascular treatment is the first of choice. First approaches are preferred in diabetics due to higher surgical risk, and bypass surgery may be needed in long segment block or multi-level disease. Success is often limited by poor distal runoff and infection risk in diabetic patient. Newer developments, the stem cell therapy is promising in chronic vascular ischemic lesions, the critical limb lesions, and wearable perfusion monitors are available in some higher centers. And prognosis usually will be bad and unpredictable. So many surgeons try to evade from treating this peripheral arterial disease, because sometimes because of in chronic diabetic patient, multi-segmental block, it may prognosis we cannot predict. So patient will be quite all right for first few weeks. Suddenly within 2 days, gangrene will develop in the toes or things. So increased mortality from cardiovascular disease also is a worst thing. And screening program should be initiated by government, and the government of Tamil Nadu already started initiative and pilot project from Tanjavur Medical College. They are starting this countering this peripheral artery disease. And to conclude, peripheral artery disease prevalence is higher in patients with diabetes than in general population. And the prevalence of peripheral artery disease in India is between 4.5 to 29%. In the community prevalence, it's very less, 4.5 to 5, whereas in hospital setting, 29, depending on age, community, and institutional studies. And diabetics tend to develop PAD 10 to 15 years earlier when compared to non-diabetic population. And disease in diabetics is more often distal, segmental, affecting arteries below the knee. And the peripheral artery disease is a systemic atherosclerosis marker. So thereby we have to screen all the other systems like cardiovascular and cerebrovascular system. With this, I conclude my talk. Thanks for patient listening.